Dr. Singh? Dr. Singh? Dr. Singh. Okay. So welcome to 2020 and our first province-wide round, and I'm delighted to be able to introduce Sam Silver. So Dr. Silver is an assistant professor at Queen's University in Kingston, and he trained in Toronto, has been a Crescent Fellow and now is a Crescent New Investigator, and also received his Master's of Quality Improvement and worked with Glenn Chertow and others at Stanford University. So he's now spearheading the CNTN engagement group, consumer engagement group, and communications and extension group. CNTN is the Canadian Nephrology Clinical Trials Network, and has also been very instrumental in actually developing a group of people, pan-Canadian, interested in quality improvement and implementation sciences. So for 2020, I thought there's no better place to start than at the beginning with quality improvement and why we should all care about it. So I'm going to hand it over to you. Thanks for coming.
Thank you. Okay, thanks, Adira, and thanks everyone for having me, and welcome to 2020. And I guess this is the one situation where you're supposed to push the red button, so I'll have to remember that. So today we're going to talk about quality improvement in nephrology, what, why, and how. These are my disclosures. So I have talked about quality improvement before in the context of mineral and bone disorder and AKI dialysis, but most of the examples I use are not going to involve that today. And hopefully we'll cover these 4 objectives by the end of the talk. The first is to recognize the differences and similarities between quality assurance and quality improvement. The second is to illustrate the benefits of quality improvement in nephrology. Third is to demonstrate actually how you can complete the quality improvement initiative, so what, why, and how, and then tie things up by looking at the current state of quality improvement in Canada and propose potentially some strategies where we can move things forward and enhance collaboration. The first step is it's hard to measure something if you can't really define what it is. So I like this example from the U.S. Supreme Court, where one of the judges was talking about quality. So the quote was, "I shall not attempt further to define the kinds of material, quality of care, but I know it when I see it." So that's how a lot of people in medicine will describe or try to define quality of care. I know it when I see it, but it's really hard to measure something if that's your definition. So about 20 years ago, the Institute of Medicine came up with different domains of quality in an attempt to better define how we provide high quality care. And this is a modification of the domains from the BC Provincial Health Services Authority that Adira was kind enough to share with me. And it's mirrored after the IOM framework. They separate patient-centeredness into acceptability and appropriateness. And it's a really nice, actually easy to read document, because they give tangible examples to give us a feeling for what high quality care is. So in the acceptability domain, care that's respectful of the patients, one of the examples is, are we doing bedside rounds? Are we presenting cases in front of patients? Appropriateness, care that is evidence-based. Are we using certain protocols to ensure that evidence-based care is being provided? Accessibility ties into wait lists. Safety ties into infection control. Effectiveness ties more into the protocols and evidence-based care. Equity into social determinants of health, and efficiency into things like costs. So this is one way where we can tangibly measure, are we developing high quality care or not? Another useful framework is the structure, process, outcome framework that's been in the literature for almost 30 years now, and was recently summarized by a group in the US where, based on the changes to policy in the US, quality improvement and quality assurance is going to become a pretty hot topic. And the idea behind this framework is there are certain structures, certain attributes that are required to deliver high quality care from a human resources and organizational perspective. And you can think of an example being what our nursing ratios or our staffing ratios are in the dialysis unit. In Ontario, I'm actually very interested in the dialysis unit. It's almost a 50-50 split between staff, how physicians round on the dialysis unit. Half the units will have their own dialysis shift, and then the other half of the units, they'll rotate every 2 weeks. Anecdotally, when you talk to patients, they have very strong feelings about which model they prefer, but no one's really looked at how that structure affects quality of care and outcomes. We're in the process of doing that now. Process is what's actually done to deliver and receive care. So the examples there from a hemodialysis unit perspective are, do our staffing and nursing ratios allow us to deliver processes such as influenza vaccinations? How do they affect our anemia protocols? How do they make harder or easier our ability to document advanced care? And then the big assumption is that by putting the right structures and processes in place, we will improve patient-relevant outcomes. And we'll talk a little bit about whether that's indeed the case or not. And in the recent update to the IOM report, there's this really nice figure they came up with where they combined those two different ways to measure quality of care. The domains on the bottom that we looked at before, safety, effectiveness, efficiency, person-centeredness, equity, and timeliness, combined with structure and process to improve outcomes to give a starting point on how we can come up with ways to measure and define quality care and perhaps develop quality indicators that we can use to either motivate quality improvement initiatives or, in some cases in the U.S., accountability measures for pay for performance. And so these quality indicators that you can create can be used for different reasons. So there's a lot of interest in the acute kidney injury community, which is kind of my second hat. I do a lot of research into long-term outcomes after AKI, and there's really a dearth of quality improvement initiatives in the field of acute kidney injury. So some of the international leaders combined this group to come up with potential quality indicators that could drive more quality improvement initiatives in acute kidney injury. Not for pay for performance, not for accountability, but because there weren't many quality improvement initiatives taking place, and they wanted to provide a framework for people interested in doing quality improvement in AKI as a starting point to kind of start and drive the process. So this is just one sampling of potential quality indicators looking at CRRT that one of my colleagues, Alexa Rewa, who's an intensivist in Alberta, led, and they broke them into certain structural quality indicators. Does your CRRT unit have trained personnel? Does it have the machines available? Does it have a 24-hour staffing model? Is it able to deliver certain processes? So what prescription, are medications being adjusted within a certain period of time? And tying that into outcomes, what are your bleeding rates, what are your clotting rates, et cetera. Some of these are more practical than others, and we're currently in the process of actually taking some of these indicators and seeing how usable they are to drive a real quality improvement in the intensive care unit. But you contrast these indicators, which are more to get things kick-started, with the U.S. indicators. So these are quality indicators currently part of the U.S. Quality Improvement Plan for in-center dialysis being used for pay for performance. So if you're not, and I'll explain what this alphabet soup is in a little bit. And the idea here is if you're beyond a certain percentile on achievement of some of these indicators, they will withhold 1% to 2% payment to the dialysis facilities. So clearly you want these indicators to be really valid, rock-hard indicators. I think one of the things I observed here looking from 2016 to 2020 is everyone's adding things. Nothing's being taken away. There's just more and more and more and more indicators. Now we're in the year 2020, so what's this alphabet soup mean? So the current indicators in place in the U.S. for pay for performance are KT over V, VAT is vascular access, BSI is infections, SRR is 30-day readmissions, and there's a hypercalcemia measure, which if you look at why there's a hypercalcemia measure, the reason is because there was no hypercalcemia measure, so we should have one. STR is the transfusion rate. There's the ICH CAPS is a patient experience survey. SHR is SHR is a hospitalization rate, and then the other is mineral metabolism, anemia, pain, depression. I don't have to remember what the alphabet soup is. And the HCP is influenza rate of healthcare workers, and then UFR is the controversial ultrafiltration target, which I'll talk a bit about in the next slide. So I think the take-home point from this slide is more stuff keeps getting added, nothing gets taken away, and if you look at how the National Quality Forum in the U.S., which also validates quality indicators, only 4 of these are valid by the National Quality Forum validation process, which I'll explain a bit later in the talk. So when you're doing pay for performance indicators, you really want those to be, especially the process indicators, you really want them to be solid indicators that are going to drive evidence-based care. And I think these 4 points are good take-home measures when you're coming up with paper performance indicators. You really want there to be a strong evidence base that that process is going to improve outcomes. You want to make sure that that measure really captures that process that's going to be provided. And the example I like to give is either discharge planning or goals of care documentation, kind of an abstract concept. Just documenting that that's been done. Is that actually a representation that high-quality discharge planning or high-quality goals of care have been provided? Not necessarily. And then if you look at the next step, the process has few intervening care processes must occur. Well, when you think of what the purpose of goals of care planning is, it's to provide patient-centered care and perhaps reduce intensive care at the end of life. Well, there's a lot of steps that have to take place between that checkbox and that patient-centered outcome. And then the fourth is implementing the measure has little chance of unintended consequences. This is where that ultrafiltration rate comes in, where if you're not familiar with it, if patients are, if the ultrafiltration rate is more than 13 milliliters per kilogram per hour, which has been associated with bad outcomes, there will be repercussions on a paper performance level if your patients are being dialyzed above that ultrafiltration rate. So you can imagine if you have patients who come in overloaded and they're going to exceed that target, nephrologists may stop removing fluid and may or may not be able to bring them back for an additional session. Clearly, there's a chance that that could produce some harm. So that's why there's a lot of controversy in the U.S. regarding that new indicator. So the idea behind the quality indicators is that at the top they get developed, and they can be developed using either what's currently in use or new quality indicators can be developed. But the key thing is stuff has to happen. So that's kind of the bottom part of the slide there. And you actually need to take those quality indicators and test changes and do something different in order to actually improve care. So that's kind of the missing link behind quality indicators. If they're necessary to improve care, then you need to take that next step to actually move care forward. And so that's where I wanted to highlight the difference between indicators that are being used for accountability, accreditation, pay for performance, which are really outcomes of aggregate data. They give you a goal or target. They tend to cycle every 6 months or quarterly. And the question that when you look at them is performance now better than it was last time? Nothing's really changed. You haven't potentially done anything that would make that indicator different except providing the data. Whereas when you're using indicators for improvement, the question is more, how are these outcomes affected by processes? So you've actually done something different. You've actually made a change to your system. And the question is, did this new change that we've done to our system move the indicator in a tangible way? So they're complementary but slightly different. And I think that point's made a little bit more explicit in this table, where you look at what the aim is. The aim of assurance is more accountability, comparison, see where we're not doing well, whereas improvement is you're actually testing something in a local practice. There's no changes with assurance, but there are changes when you're using an indicator for improvement. Assurance tend to have large sample sizes throughout a province, whereas improvement is going to be local. There's no hypothesis with assurance because there's no change, whereas there is with improvement, and that could be flexible because you're learning information as you go when you test your changes, which I'll explain about later on in the talk. There's no testing strategy because there's no changes with quality assurance, whereas with improvement, again, it's iterative, go as you learn. Assurance, the data turnaround is slow, whereas for improvement, you want it to be fast, because if you're only getting the data quarterly, well, you're probably only going to learn from your changes on a quarterly basis, which is much slower. And then improvement data you usually want restricted to the improvement team because a lot of your changes won't work, and people don't necessarily feel, especially myself, most of us in medicine, we don't feel comfortable with failure, whereas quality improvement is a business where a lot of your changes aren't going to work. And I think we need to start becoming more comfortable with that and not being afraid to test some of our new ideas to figure out whether they're working or not. And I think, I was talking with Adira yesterday, I should create another column for where implementation science fits in, which is more looking at how to spread evidence-based change in a generalizable way, which certainly is complementary to both quality assurance and improvement. So when looking back at these indicators, they can be used for pay-for-performance. They can be used for assurance, certainly, if they're cycled quarterly, but they can also be used for improvement if they're being cycled at a local level at a faster rate where a unit is actually testing changes to try to drive them. So I think about my unit in Kingston. I get these emails on a monthly basis with several of the indicators here, but most of the time we're not actually testing any changes around them. And the title always comes in, continuous quality improvement spreadsheet, and it always irks me. I really need to change that next time. I'm going to go back there and do that. So the way I think these can complement themselves, so to drive improvement, is by kind of tying the two in an observable public way. So this is an example of a quality improvement board from sick kids, but these are starting to become a lot more the vogue inside hospitals. I'm sure there's some in use at some of the hospitals here. And I think where these can become really effective is they take those big dot quality improvement indicators and make them observable to the frontline staff who need to be the ones driving change. So you can create this board where you have your quality indicators at the top, and staff submit quality improvement cards to suggest changes that can drive those indicators. And then there's a process to look at ones that, oh, these are really easy ones that we can do right away to move that big indicator, and oh, these are ones that are going to be a little bit harder that we're going to need hospital resources to do. And you can track which changes you've actually implemented and line those up on your board, and then you can see one day, are you actually going to move that indicator? Because certainly if you're not testing any changes, there's no way you're going to move the indicator. And this board makes things observable, not only to the frontline staff, but when ideally used, it's in a public space where patients can also see it, and it becomes observable what type of improvement activities the unit is doing to drive healthcare quality. Okay. So that's what quality improvement is. Now I want to spend a little bit of time talking about why I think it's important, especially in nephrology. And a lot of things we do in healthcare, not just quality improvement, but clinical research as well, is trying to drive what used to be the triple aim, which is improving healthcare outcomes, so better outcomes at lower costs that improve the patient experience. And more recently, it's become the quadruple aim, and again, the theme is something always gets added on. We can't just be happy with three things. We need to keep adding stuff on. So the thing that's added on is the improved clinician experience, or joy in work is what Institute of Healthcare Improvement has been coining it. I do think that's important to keep in mind, because the purpose, I think one of the strengths of quality improvement when it's done right is it's supposed to make work easier and more fun. What ends up happening is more checkboxes to tick, more forms to complete, when what should be happening is kind of a triaging of non-value-added care and care that's making things more difficult, that's affecting the clinician experience without improving better outcomes, without improving costs, without improving the patient experience, and trying to drive the things that make our work easier. That's when quality improvement's done well. So that's why I think it's important to remember that. And I don't know if Einstein's actually responsible for this quote, but I include it because if we keep doing the same thing over and over again, we're always going to get the same results. This is one of the mantras of quality improvement. Not all change is improvement, but all improvement is going to require change. We actually have to test things, or if we go into clinic every day with the same stuff that's bugging us, so the thing that's bugging me now is every time I go in the CKD clinic, there'll be a patient with official access who's a younger patient, and we don't know if they've been assessed for preemptive or living transplant yet, and we always have to go look through the chart and figure it out, and it takes a bunch of time, and that's really starting to irk me. And I haven't done anything about it yet, and it's not going to change if we don't actually do something about it. So, and we do have evidence in nephrology that quality improvement interventions have improved care across all domains of nephrology. This is a meta-analysis that we did. I thought it was older than 2 years ago, but I guess not. And this is one of the dangers when you create a visual abstract, it ends up turning into a slide. So we have to at Crescent Adira have a session on visual abstracts, I think. So this is a meta-analysis we did where we looked at patients with non-dialysis chronic kidney disease. We looked at whether a quality improvement strategy affected a clinically relevant outcome like mortality, dialysis incidence, blood pressure, things like that. And we only looked for randomized control trials. And we identified 15 patient randomized control trials and 6 cluster level randomized control trials. So that looks like a big number, 20 trials. When you look at other chronic diseases like diabetes, which is close to 200 trials, and you look at heart failure, hypertension, many more RCTs than we were able to identify in this chronic kidney disease population, and we were a little bit underpowered as a result. But we did see in a few of the outcomes where we had an adequate number of studies that these quality improvement interventions were able to reduce dialysis incidence, were able to reduce cholesterol by about 0.5 millimole per liter, and were able to increase the evidence-based use of ACE inhibitors or angiotensin receptor blockers. Now, we wanted to actually try to identify which components of the quality improvement interventions actually drove these outcomes. In other chronic illnesses, it looked like case management and team-based changes in a structured way, combined with a patient self-management intervention, were driving the outcomes, but we were underpowered to do meta-regression to kind of identify the exact components of the quality improvement interventions drove the outcomes. So the take-home from this slide is there is certainly potential for quality improvement interventions in CKD to improve outcomes. We're behind a lot of chronic illnesses, and I think one of the detriments is a lot of this work is not RCTs, and it doesn't get published or highlighted or shared as a result. And so I just wanted to highlight, since that meta-analysis, there's been, I think, a lot more quality improvement work starting to be published in the literature in some of the different domains and disciplines of nephrology. This is a study we did looking at routine hemodialysis blood work. That's one of the pains in my dialysis unit, is doing blood work every 4 weeks. The staff, looking at the clinician experience, the staff didn't necessarily enjoy it. We didn't necessarily think it was a value-added activity, and when we changed that to 4 to 6 weeks and looked at close to a 18-month period before and after, we saw that we made really no difference on patient-relevant outcomes like our anemia targets, phosphate targets. You can argue whether that's an evidence-based outcome or not, but also mortality didn't change, and we were actually saving money by doing less lab tests. Even when we added up the additional lab tests that might have been ordered in between sessions, we were still doing less blood work when we changed from 4 weeks to 6 weeks. And talking with the DRA yesterday, it sounds like a lot of this change happened in BC, but just didn't get published, so we didn't know about it. And so this is where publishing some of our quality improvement work can help spread these best practices. So here's an example of a project targeting perhaps costs and targeting the clinician experience. And looking at in the peritoneal dialysis or home dialysis population, this is a graph looking at rates of PD peritonitis in Australia and New Zealand. So hopefully some of the, we had dinner last night and a lot of the fellows are from Australia, so hopefully they're familiar with some of this work. And this shows that rates of PD peritonitis were high, and they put in the structures and processes in place to help individual units improve this. So there was no way really to measure PD peritonitis in a standard way. So they began doing that and providing that information to the units, which is necessary but not sufficient, and combined it with things like education and protocols and webinars. And you can see over time the rates of PD peritonitis decreased. So example of a project here improving patient outcomes. In the transplant population, here's a nice study out of Ireland looking at a one-day living donor assessment model. So you can see in the yellow there, you don't need I don't need to put a p-value on here, but you can see here in yellow, that's the number of living transplants being done at this single center. It was low up until 2010 when they started doing their one-day liver donor assessments. The idea being that before this change, these liver donor assessments in Ireland could take up to 2 years, and they thought that was one of the main reasons why their living donor rates were so low. And when they put in doing all the tests at 8 a.m. and finishing at 4 p.m. and patients getting listed 2 to 4 weeks later, they saw a drastic increase in their living donation rates. So here's an example of a project improving the patient experience. And I think what's also interesting about this project is it helped them get more resources to drive transplant later, because they were able to show their hospital that, oh, there's more living donors interested, so now we can provide more resources to actually do the operations. And so I think where I hope quality improvement is going is more projects like this, which is hot off the press, just published on KI in proof form, I think in the last few weeks. And it's a prospective multi-center quality improvement study looking at a bundle that consists of creatinine-based alerts and a pharmacist-based intervention in non-critically ill pediatric patients who are receiving either an IV aminoglycoside or 3 nephrotoxic medications off this list. And these involve pediatric centers in the U.S., from San Francisco to Alabama to Washington, so all across the country, different centers, different contexts. They just needed to buy in to these 5 or 6 key things. They needed support from leadership. They needed a system to identify patients who were on nephrotoxic medications. They needed a dedicated pharmacist or a pharmacist interested in providing the information, and then had to be willing to provide this data over time and meet to kind of discuss what worked with the alerts and what was working with the pharmacist-based intervention and what wasn't. And this is I don't like putting busy slides on here. The reason I included this slide, which shows the rate of AKI per 1,000 patient hospital days on the y-axis and then time on the x-axis, is because this is an example of a statistical process control chart, which is kind of the bread and butter of quality improvement, because it lets you see how your outcome is changing over time. And what the journals tend to just ask tons of questions about these. A lot of them ask for before and after p-values, which don't quite give you the same amount of information. So I'm including it so that we can all be a little bit more comfortable looking at these type of graphs, which essentially shows your outcome on the y-axis, time on the x-axis. Those red dotted lines are your control limits, which you can think of roughly 3 standard deviations from the median or mean, which is usually your solid red line there. And then that blue line is your outcome, which varies over time. And then there's certain trends and patterns that you look for, which can help you determine if you have a statistically significant change. So in here, the yellow is their primary outcome, which is their rate of AKI, which went down over time by a relative rate of approximately 20%, which is close to their target. And which is also nice about this graph is what they included in blue, which is what their change was, their take-up of their change. So I think I would have liked it if they had just put big, instead of all the blue, which I think is hard to, the blue boxes, which is kind of hard to follow, you can actually put with an arrow when your group did this. So when you started automating the creatinine alerts, you can put on that with a star, and hopefully after your star, you start to see a lot of improvement. So that's a nice tangible visual representation that that change probably had an effect. And in here, you can see their change started out in the mid to high 50%, and over time, these 9 centers were better able to implement that change close to the 75% value we like to see. But I think this is really cool. This is one of the first studies able to reduce and prevent AKI. And I think the other thing that's really cool about this study is centers could only get to a certain level of AKI prevention. So if a certain center started off at a certain AKI rate and they were doing really well and had really low AKI rates, these changes actually made no difference, which suggests that those centers, but all the centers were able to get to that rate. So at the start of the study, there was a lot of variation. At the end, all the centers were at the same high excelling low rate of AKI, which suggests that this is as far you're going to get with this creatinine-based alert nephrotoxic medication prevention bundle. And if you want to get even better, you're going to have to do something different. So you've improved your system, you've created a new system that is probably not going to operate beyond the current capabilities. So I think that's really cool. I can't wait till it finally gets published in full. And so I've shown you, kind of the argument now would be, Sam, you've cherry-picked a few studies that showed benefits. Yes, I agree, I have. But I think the other value of why we should do quality improvement is because even if what you're doing doesn't get better, and in here, poor Dilbert just followed the same process 30 times in a row, and it didn't work, and they know it didn't work, but at least now they know that that didn't work. So they've gained a piece of knowledge. Whereas I think in medicine what we like to do is we all like to do our own slightly different thing because we all know the way that we do it is the best, but we don't actually know the way we do it is the best. And if we actually sequentially tested how each of us do it, we'll actually gain some information about which ones are actually better than others. So we can learn that these routine interventions that we're doing, which ones are working and which ones are not. So if we test a change and it doesn't work, we've actually gained a piece of knowledge and can either improve that change to drive improvement forward, or we can abandon it. And I think that's something where we really need to get more comfortable. And there was actually this editorial in New England just a few weeks ago looking at this concept of randomized quality improvement trials, where at the hospital level, they were randomizing influenza alerts, they were randomizing things like hospital-based phone calls. So they actually knew if we provide this influenza alert at this point in time, we will improve our influenza vaccination rates by this much. And they actually were able to learn if we provide a phone call within this time period, it will actually make no difference, so we no longer need to do this. And I think that's a really cool concept where what we tend to do, especially at the hospital level, is introduce an intervention in a non-randomized way, and we actually never figure out whether it's working or not. But it's been rolled out in full, and it's just become the way of doing things now. Okay, so that's the what and the why. So now, which I think has a lot of people are starting to become more familiar with. And what we found out a couple of years ago is that how do you actually do the quality improvement project was a little bit of a black box. And I think a lot of the community sites and academic sites too, this is becoming an expectation of our daily work, as it should be, to try to make work a little bit easier and better. But you can kind of, when I was thinking last night, you compare it to when we recruit patients for randomized controlled trials at community sites, we're usually providing them some help. And that's one of the big things that we're talking about at the Canadian Nephrology Trials Group, is how we engage community sites and provide them support. Well, the expectation on quality improvement is that all the sites are just going to do it themselves without any knowledge, support, or training. And I think we need to move a little bit beyond that if we're going to really take quality indicators and drive improvement. So this C. Jason series was an attempt to do that. And the series kind of focused on the model for improvement as a framework for driving change, which I think a lot of people have seen before. I'm not really hung up on which improvement model people use. The idea is have, just like you do clinical research, have some type of model or system that you follow in a standardized way. And this kind of mirrors clinical research in a way. You pick your aim and your objective. How will we know that a change is an improvement? Well, that is your outcome. And then afterwards, what change will result in improvement? That's kind of your exposure. And I always kind of teach this in the opposite way, because I'm always used to the PICO model, and this is slightly different than that. But the idea is you answer these three questions, you test changes, some will work, some won't, but at least you're doing it in a standardized way where you can get closer to improving care. And this slide was, I really like this slide. I didn't know where to put it. So I decided to put it here so I could rant about it for a couple minutes. So one of the things that kind of bogs down quality improvement work is everyone asks for, what's the gap in care? Someone do a retrospective chart review. Show me there's a gap in care, and then we'll target it from there. How many charts do we need? We need a lot of charts. We need, hundreds and hundreds of charts. And this graph just breaks down the proportion using the binomial equation for the 95% confidence interval. So all of these differences equate roughly to p-values less than 0.05. And the reason that is because in improvement work, you want to look for big changes. We're not trying to get from 88% performance to 89% performance. If you're trying to do that, you're going to need a lot of charts to show a gap. So how you should use this figure is you guess at what your observed system performance should be, or what you would like it to be, where it's worth your blood, sweat, and tears to undertake that improvement initiative. And usually you're looking for something that you're doing at a 50, 60, 70% level. So you see, if you take 60 on the observed performance level, and your chart shows that you're doing 80%, you only need to look at 25 charts to have a p-value less than 0.05 at that level. And if you want to be doing your process at 90%, even better, you only have to audit 10 charts. So I think this concept of small chart audits, picking at what level of performance that you need to do and where it's worth your while to improve change is a good way of not getting bogged down in these large chart reviews looking for a care gap. Okay, so rant over. So returning to the model improvement now. So how do you come up with an aim? We want to make smart aims. What does that mean? You want your aim to be specific, actually say what your quality improvement project is about, what population it's going to target. You want it to be measurable with hopefully a number there of some kind. You want it to be obtainable, but I put in there not too easy, because if you try to do something 1 second faster or a few minutes faster, you can just work harder to achieve it, and then you get tired, and then you revert to the prior performance. So you want it to be not too easy, so it actually involves some type of tangible change in the system or change into the way work is actually done. You want it to be relevant, so that's where there's an opportunity to tie it in to your provincial or center quality indicators, and then some type of time limit to it. So if you look at the nephrotoxic AKI project, we aim to reduce AKI, okay, not great. You can make it a little bit more specific. We aim to reduce nephrotoxic associated AKI, a little better. And then this was actually the aim in their manuscript. We aim to reduce nephrotoxic associated AKI by 30% by the end of the project. So I think it's getting better. It's specific. They could say by what criteria they measured AKI potentially. It's measurable. There's a number there. It's certainly obtainable, but 30% would be also a huge change. It's actually going to require you to do something different rather than just working harder. It's certainly relevant, and I think they could have put the time for the end of the project there as December 31st, 2020, for example. But that's what I mean by smart aims. And so then medicine, most of the time we diagnose the problem and then treat it. I remember back to my residency, we were trying to come up with the one pill that could treat every patient in the emergency department, which was some combination of like an antibiotic, lactulose, and Lasix all in one pill. And that's where you kind of treat something before diagnosing it. But most of the time you can think of quality improvement like a typical patient. You want to diagnose what the problem is in your system using certain tools that for the interest of time I'm going to slightly yada over. And then hopefully that exercise will allow you to pick change ideas that actually target the problems that you've diagnosed. And so this kind of sums up with what a lot of the time is usually done. We're hiring a director of change management to help employees embrace strategic changes. Or poor Dilbert says, or we could come up with strategies that make sense that employees would embrace. That sounds harder, because it is harder. So how can we do that? So this is a nice example of looking at a fall prevention program in an outpatient hemodialysis unit, where in their methods they talk about using root cause analysis. So I'll show you a couple of the tools that I think they used, in which an adverse event's examined from all the different causes, and then they targeted what their changes were, their interventions, based on that diagnostic exercise. So these are two examples of, so I'm not completely yada-yadding it over, but I could do kind of a whole talk on this root cause process. On the left there is an example of a fishbone diagram where you take what your quality of care problem is. So in this case it would be falls. You put that on the right, and then you look at the problem in terms of what policies are driving falls and list those causes there, which people and what potentially are risk factors for falls, and list those potential causes there, what places could falls be occurring, what procedures are leading to falls, etc. And then you have a nice list of potential causes for falls or for your quality of care program. On the right is an example of a process map. So you can envision here a good idea might be following some patients to actually map what happens to them from the start of end of dialysis. So you'd involve a multidisciplinary team, follow the patient, and what you want to do is actually map what the patient's actually doing, not what your policy or protocol says they should be doing, what's actually happening. And then through that process, when you look at it in your team, you could identify, oh, here's where the fall's occurring, or oh, this step shouldn't happen. And so what they identify, and this is like the scariest outpatient hemodialysis unit to me when I look at this slide, is, okay, fine, they identified a high-risk population and addressed that. They found that a lot of patients were tripping over this elevated scale, so they put an in-ground scale. So targeted their change at that potential cause. Apparently this was also a very dark unit, because it sounds bad, so they added lights. Apparently all the floors were wet too. And I want to know where this was. I have to talk to Michael about this. But you can see how that root cause process helped them target their changes. Now it's not always that easy. So I don't like giving guidelines for innovative thinking. So I'm going to talk a little bit about kind of some principles where if the changes aren't apparent, or you have a list of different changes you can try, what potentially makes for a good change and what potentially doesn't. So I think your change should give you an immediate advantage. It should make work easier. Where my changes have always failed is when I try to make work harder, potentially with an extra box to check or with an extra checklist. So always think about, are you making work easier? I don't always think optimistically, but when I like to think optimistically, I do think that every healthcare worker comes to work every day wanting to provide better, high-quality care. But when you add in, okay, we're going to triple the amount of work you do or quadruple the amount of work you do in order to do that, that is a tough sell, even to someone every day who comes to work who wants to provide high-quality care. So I think that's the most important one. And then it kind of spirals down from there. Is your change easy to understand? Is it compatible and consistent with how we do things? Are we able to test it first, or and decide if we like it or not and change it a bit? Or is it just, this is how it's going to be? And are the changes, obvious? Is it something that you need to send us data in 6 months to see if the change works? Or is it something that we can see that this change right away is improving care? Kind of like increasing the lighting. Okay, right away, that's making things a little bit easier in order to prevent falls. The other principles I like to think of with changes is to try to target design-oriented changes rather than person-oriented changes. So I like thinking of education in quality improvement as necessary but not sufficient, because people are very wily and very able to work around educational initiatives, even very well-meaning people. I was just on call over the weekend, and we have these different CRRT order sheets based on the different bags that you're using. And there's a compartment where you can mix the bags. And on one of the order sheets, I think whoever made them just copy and pasted the order sheet for the same bag over. So there's actually an option on the order sheet to mix the bags when there's no clinical situation in which you'd ever want to mix the bags. So it's possible to mix them for some reason, but there's no clinical situation in which you would want to mix them. Yet that's an option on our standardized order sheet that can be checked. So you can provide as much education and rules as you want about that, but it can still be worked around. What would be most effective is the top of that list, a forcing function or constraint, is that needs to come off that order sheet right away, and then it's impossible to do it. And so I like to think of a good change. Is it something that can be conveyed in a picture? So here's how people tell me we used to drink soda with a can opener, right? There's no way to open it. You need to take this can opener, you're going to twist it around, you're going to cut yourself, and it's RC Cola. It's not even Coke or Pepsi. And whereas here, I had to put an arrow on, so it's not quite visual. But here's your pull tab. So it's something that hopefully provides you an immediate advantage. Hopefully you're opening soda quicker with the pull tab than a can opener. And it hits a lot of those principles of a change that gives you an immediate advantage. It's compatible with how we do things. We're still opening the can from the top. It's observable because you're getting the pop right away. And so I like to, when I was thinking, what's a nephrology example, I think the foot off dialysis for patients on in-center dialysis looking for ulcers. That's a nice change that I know is big in British Columbia that you can observe, right at the bedside. Patients with their feet off, whether there's evidence of issues with foot care or not. Nice, observable potential change in practice. Okay, so we summarized how we go from an aim statement to coming up with change ideas. And we talked about what changes will result in improvement. And so how will we know that a change is an improvement? So that second question, what are our outcomes? And this is similar to clinical research in a way. So you have your outcome measure, which evaluates the effect of a change on a system. You have your balancing measure, which looks for unintended consequences. And I think the really key one that I want to hit home is that process measure, because your outcome measure can sometimes take a long time to move when you think of something like dialysis incidents, whereas your process measure should be something upstream that is related to your change right away so you know whether your change is working or not. So looking at our AKI example, I think rate of nephrotoxin-associated AKI is pretty good for an outcome measure because it actually occurs right away. So we don't have that dialysis incident problem here. There are process measures where rate of nephrotoxin exposure and percent of patients getting daily serum creatinine. So if these things aren't being done or improved upon, there's almost no point to look for a change in your outcome measure because you haven't made a change in your system yet. So this is the one big problem that I see in quality improvement work is people are looking for changes in their outcome measure too soon before any evidence that the processor system has changed. And you can imagine in this work that if a lot of nephrotoxic medications got held, that patients could be dying of sepsis because all their antibiotics were being stopped, but that wasn't the case in this study when they looked at their balancing measure of all-cause mortality. So I'm just going to skip over PDSA cycles because I think we're all familiar with that, where we plan a change, do it, study it, and act upon it. And over time, by testing our changes, we learn information that takes us from a simple change to a change that results in improvement. Because I want to talk a little bit about where we are currently in Canadian nephrology, looking at quality indicators and potential collaboration for quality improvement. So that's the fourth objective I'm going to cover in the remaining time. So this was a survey done by Dave Mendelson a couple of years back, and the take-home point from this is 80% of nephrologists surveyed thought that there were performance measures that nephrologists should be held accountable for, which begs the question, which metrics are these? Recently, we've combined nephrologists across Canada who have expertise and interest and on-the-ground level in quality improvement. From BC here, we have Chris Ponin and Claire Harris involved, to people in every province all the way to the Atlantic provinces, where we cataloged what an environmental scan to kind of take a look at what's out there and an initial stab at how good our indicators are and what they're measuring. And we evaluated them looking at the AHRQ and the ACP criteria for how you evaluate an indicator. And that's a modified version of this table where we look for a performance and gap, we look at how the indicator is defined and specified, we look at whether it's valid and reliable year after year, and then we also look at whether there is a conceptual model in place to actually improve that indicator. And what did we actually find? So we looked at these indicators across the four different domains of nephrology. And we found a lot of measurement going on. So overall, we found close to 150 quality indicators, different indicators in Canada being used. We found a small proportion of them, most of the time less than 50%, being valid by those AHRQ and ACP measures, and that's actually pretty consistent with the U.S. internal medicine indicators when they go through the same process. And we found, with the exception of transplantation, we found very few common measures, and a lot of those common measures weren't necessarily the valid measures. And in transplantation, there's a lot of good work going on being led by Greg Nall, combining international leaders in quality indicator development to kind of recommend and develop new indicators for use in the field of transplantation. So it'll be exciting to see that work when it's ready. And what kind of elements were these quality indicators looking at? So in chronic kidney disease, they were looking at things like statins, home dialysis assessments occurring, deferred dialysis starts. In in-center anemia, most of the common indicators were looking at anemia, vascular access, infections and goals of care. In home dialysis, prevalence and incidence of home dialysis use. And in transplant, looking at the donor workup time, wait times, and certain transplant outcomes. I think the main thing missing here, and the reason I put this slide up, is there's very few patient-reported, patient-experienced, patient-centered outcomes on this list, which is a gap I know BC and Ontario are trying to work on, hopefully together, so that we have kind of a combined patient experience measure that we can combine amongst ourselves. So this is a cartoon Adira shared with me, which kind of I think sums up our environmental scan, where our new dashboard has all the different indicators we can track now. What's that indicator at the bottom right corner there, tracking to 0? It's how well we understand them all. And this is important because tracking all these indicators costs a lot of money. In the US, this is $40,000 per physician. I don't think it's as high here, but we're doing a lot of measurement and maybe not necessarily a lot of improvement work, not testing a lot of changes for some of the reasons I explained earlier. So we were all laughing a little bit at how many indicators there are in the US when they were measuring 15 to 20 across the entire country. And we've got close to 150 indicators and little overlap. So I think we have an opportunity here to kind of combine things and come up with a standard approach between each of our provinces. So we can think of our current state where we've got 150 indicators. We're starting to get more people trained in quality improvement methods. We have little sharing of our successes. They're not published. There's no repository for things that are working in one jurisdiction or not. So things are spreading slowly, where we can come up potentially with a future state where we have common prioritized indicators across provinces. We have a system where we can help and mentor academic and community sites, building upon our expertise of people who've developed advanced training in quality improvement. We can list what projects have succeeded and which ones have failed, which I know Chris Ponin is taking a lead on developing, and in that way perhaps spread practices more rapidly. And if you think this is impossible because we're all in different provinces, we have different health information systems, different reimbursement systems. Remember, they were able to do it in the US across 9 different states, Alabama, San Francisco, tons of different jurisdictions. So we're in the early stages of putting this together. We have representatives with quality improvement expertise across Canada, and we're in the process of involving patients and pharmacists and other allied health. We're looking at creating work groups who are looking at harmonizing indicators, looking at educating and providing mentorship to academic and community sites, and looking at driving hopefully one national initiative per year, driving a chosen upon key indicator across the country. So there's definitely opportunities there for people, even without quality improvement experience, to get involved in those sub-work groups. So, in BC, please contact Chris, please contact Claire Harris, contact myself if you're interested. And the idea would be we'll increase the number of shared indicators, we'll increase the number of education sessions, we'll increase the number of multi-site projects, and hopefully improve patient-centered performance indicators. And in an effort to improve reporting of all of the quality improvement that I think is going on in Canada but not being published, recently went live is a special collection on healthcare quality in the Canadian Journal of Kidney Health and Disease, which I'll be guest editing along with Jay Hingwala in Manitoba and Claire Harris here. So if you have a small project, if you have a narrative review, please, we are very interested in highlighting this work, which will be promoted and showcased on CGKHD once the collection is closed. So these were our take-home points for the day, which I think we covered. We wanted to recognize the differences and similarities between quality assurance and improvement in Canada. And we saw that it's not necessarily the measure, but it's how you use it, whether it's an assurance or improvement measure. We saw the benefits of quality improvement in nephrology, and if done well, it should make our lives easier as well as improve patient outcomes. We saw how to do an improvement initiative where we chose an aim, selected a measure, tested it, rinse, cycle, repeat. And then we are in the initial stages of looking at the current state of quality improvement in Canada and looking at collaboration. And we're seeing that there's lots of indicators, lots of variation, and with emerging QI expertise, with an opportunity like the US is doing, where this is going to become a huge topic as they have legislative changes that are driving value-based care. We have an opportunity there to kind of lead in this area that I think we are ripe to take advantage of. So I'd like to acknowledge my collaborators, members of the Canadian group in BC, Claire and Chris, also Adira for her guidance, and I'd be happy in the time remaining to get any feedback or questions about that. Thank you.
Just a question. So a lot of the QI, I'm not very experienced in this area, but my understanding is a lot of QI things that get supported are things aimed primarily with the assumption that they're going to reduce costs, and there's very little traction for the things that may actually increase cost in the short term and long term. I just question whether or not you have experienced that, where some ideas just get tossed aside because they are going to increase costs. But also, like in nephrology, is the focus of your project going to be mostly like at taking some things away or adding things on? Because I think there's a lot of things that we put into place that no evidence exists for at all, and yet now we have to do a study to show that it's okay to take them away. Is that valid?
Okay, so do I have to repeat? Everyone can hear the question? Okay, perfect. So the first question had to do with cost. So I think when you're trying to get a project off the ground, sometimes that can be a big barrier. So when you're just initially coming up with and a good example would be that one-day transplant project where they would, if you increase transplant rates, it's going to be more cost with that. So what you want to do is kind of start with a change that you might think you might get resistance to. Start with your willing party, your willing members initially, and what you would want to look at then is that your change is improving some of those other aspects of the quadruple aim, so making life easier, improving outcomes, improving the patient experience, and then maybe it's not cost neutral initially, but then you are in a better place with your willing team. If you've improved some of those things, then you can make an argument to administration at a later time. Listen, we're improving these elements of care. Potentially this could lower costs at a macro level once it's implemented, but you don't want to start out big. You want to start out small with your willing team in that scenario to do your PDSA, build your evidence base before you get into that cost level argument. The second comment had to do with adding and taking away stuff. So I'm glad you asked that. We're not great at taking away stuff. So that would be the objective of kind of the performance indicator pillar, would be to curate that list on a quarterly basis. That would be part of their goals, or part of their mandate rather, so we don't get into the situation the US is in, because it's always easier to add something on. And they actually do have standard criteria by which they should be taking things away. They're just not using it. So from a performance indicator perspective, that'll be a mandate of that group. From more of a, potentially if your question's looking at the more micro level, if there's something that's not evidence based and can potentially cause harm, that definitely would be a good quality improvement project, right? That's the blood work frequency project. That's exactly what it is, right? We're doing blood work every 4 weeks. There's no evidence at all that this improves care. Let's just change it in 1 unit for 6 weeks and see if the unit explodes. Oh, it didn't. So maybe, I would argue we should be going to 8 or 12 weeks potentially. There's little, when you suggest that, there's little appetite for that. But I think we need to be testing more things like that.
This is more of a comment, but I think that one of the things that I think you highlighted that we sometimes don't do is that systematic evaluation of what the root cause is, because as physicians we're so wanting to diagnose the problem because I actually know how to treat that problem. And I think that maybe all of us could slow down when you think you see something, is to do these diagrams about what are all the possibilities, what are the big drivers, and then address the big drivers, not the thing that your pet thing that you think that you can do. And I think that's a really good message for us.
And those are mistakes I've made multiple times. So yeah, it's tough to pause a bit and do that because everyone wants to test their great idea right away.
Paul, any questions or comments? Dave, are you trying to say something or not? Just any of the other sites? No, thank you very much.